I wish to welcome Didier Coeurnelle, who is coming from Brussels, where he serves as a co-chair of HILS, Healthy Life Extension Society, and vice chair of AFT-Technoprog. He is board member of International Longevity Alliance and is the author of two books in French in Ethics and Future of Human Longevity and Technoprogressism. Didier Coeurnelle, welcome to the stage.
So, hello everybody. I will speak today about how to better share health data, how to accelerate clinical trials for healthy longevity, and why and how public institutions should work in this way, I think. And I will begin with the most important and sad aspect of what's happening now. Today, like every day, about 120,000 people in the world will die of diseases related to old age, and this is the majority of people dying everywhere in the world. About more than 2/3 of people are dying from diseases related to old age. In a country like Slovenia, it's more than 90%, but even in the poorest countries in the world, except where they are worse, but even in the poorest countries in the world, it is the majority, the first cause of deaths. So, and personally, I don't want to live forever. I want to live as long as I want to live. And, well, for example, I would say 200 years so that at the end I can speak English without any accent, or maybe 400 years so that at the end I can speak Slovenian fluently. Okay, now you know probably that in Europe life expectancy is, well, like everywhere in the world, life expectancy is going up. There was one exception. The first exception concerning the rise of life expectancy was during the COVID time, where there was a decrease, but no, we are going up again. And the situation in this small, beautiful, friendly country, sometimes rainy country, is also going very good. You have a life expectancy of 85 years for women and almost 80 years for men. So better than ever probably in the history of Slovenia. And you see, so there was like here, like in Europe, this decrease during COVID time, but happily it's going better. I want to say something because we are all speaking about living healthier and longer. This is probably a bit a schema a bit complicated. You have in yellow, brown, the life expectancy in good health, official life expectancy in good health in 2023, and in blue the same thing in 2025. And when you see that it's there is no logic there. So why do I show this? To explain to you that sadly at the moment we don't have good statistics. Even the most official statistics concerning healthy life expectancy are not reliable. Also, you don't see that here, but if you compare very similar countries like Sweden and Norway, Sweden and Finland, you have very similar life expectancy, but you have very different healthy life expectancy. So here you have the same, but it's even more spectacular for healthy life years at age 65 for women. You see how much the situation is changing, in a non-logical and non-organized way. So healthy life expectancy is important, but we have to know that we don't have good statistics. Another thing that many longevists do not know or forget is that so life expectancy is rising, but maximal life span is not going up lately, and is even not going up since 2000 years almost. So 2000 years ago, Terentia, the widow of Cicero, died somewhere in Italy. and she was 103 or 104 years old. That is always older than almost all people you know. Actually, probably all people you know, except the great mother of Alexander. And the oldest person ever was probably, there are some controversies, Jeanne Calment. She died when she was 122 in 1997, and it is still the longest lifespan ever. The oldest woman today is 160 years. The oldest man in the world today is 112 years. So we don't progress for maximal lifespan. And even more sad, I would say, we also don't progress. You know that when scientists are testing things for longevity, they use mice or rats. The longest living mice died about 20 years ago, and also there the record is not broken. So I think that it is very probably possible to find a treatment against aging within 15 to 30 years, but it will be complicated, it will be expensive, and we need AI to progress rapidly. I will come back to this. Now a few facts about big data for health. So it is often said that about 30% of big data is health big data. Where is that? It's in, for sure, in your medical files, medical doctor, in the clinics and so on. Also, your DNA information, 23andMe and other organizations. There are health data in scientific literature. There are health data in your smartphone, a lot of health data there. And also, I also always ask this, who knows about IQVIA here? 1, 2, you are, that's the best conference for this, congratulations, but for the others, IQVIA is a not small organization of 80,000 people in the US, and this organization has medical data of people in 80 countries since more than 40 years. And they don't share the data, except if you pay or except if they accept, but not systematically. So we have, our problem is not that we have, that we need health data. The problem is that we need to share health data to know which human clinical trials we could start, to know which existing drugs are good or bad for longevity and for small longevity progress, and to prepare breakthroughs thanks to AI and thanks to more research. Another problem is that you are not allowed to share most of your data for science. First, because in no country there are no tools existing now who allow you to share easily your health data. That's one. You have many tools in your, once again, in your smartphone, online, and so on, to consult health data, to collect health data, but not to share with scientists. And even if you decide to share, the scientists will have a lot of problems, so-called ethical problems to publish your data. So, so there will be no publication, so no sharing of science. So, what can we do, and what can especially the European Union organize for a faster and more useful sharing of health data? So, maybe the second question a bit similar. Who knows here about the European health data space? Oh, I'm surprised, a bit less. Okay, so the European health data space is a very good regulation who officially came, is applicable officially since March 2023, but only has real effects from, March 2025, 6 months ago, but has only real effects in 2027, 2029, and 2031. I will come back to this a bit later. So the European Health Data Space, EHDS, is a very good legislation, but it is going too slow. So I think that we should we longevists should constantly remind that most people, when they are asked, are you willing to share health data for scientific and medical goals, they say yes. And when they don't want, it's not because they don't want to share for science, that's because they are afraid that it's used for commercial goals and that it could be even bad for them. And so what I hope and what I wish, among other things, it is that we have a system, I would say it's called sometimes patent left, so no patents, at least when there is work funded with public money. And you probably know that the situation the last, I would say, 20 years in many countries of Europe and even more in the US, it is universities are funded with a lot of public money. Well, it's more in Europe than in the US. But after that, the research is somehow privatized. So we need less patents to facilitate sharing of data, publication of negative results. That is very important. If you have a company trying to prove that its product is a good product and they have results, not good results, they will not publish it because it would be bad for them. So there should be an obligation to publish even negative results, and there should be also more research outside of patentable fields. Okay, we should use what's called in the law, the EHGS law, altruistic database. So it is a database where there is no financial goal, nothing to sell. It is also good to have less risk because if health data is something that you can sell, if health data is something that you can sell, but there are more risk of hacking and so on. We need interconnectivity of databases. This is the schedule. I will not go into details except to say that March 2027 is normally the date from this date, 23 or 25 March 2027. From there, you are normally always allowed to have access to your own health data. It's very important, very positive. We will see if it is working really. And yeah, from 2029, it's also for what's called secondary use, so for scientific research. We need a less bureaucratic and faster system of authorization. I will skip because I don't have so much time. We need more open platforms to use the examples of good practices, especially Estonia, Finland are very good examples where I think are going in the good direction faster than in other countries. And we need, of course, to use artificial intelligence, but artificial intelligence today is better than humans in some aspects, but still less good than humans in other aspects. So we need to work together with artificial intelligence. And I want to say one word outside of the scope of this meeting. Artificial intelligence can also be very dangerous. I advise you to buy this book about it. And I will not go into details today, but I think that having research with really as a fundamental goal resilience and longevity and healthy life is somehow mitigating risk related to general artificial intelligence. Somehow, and it's not enough. Okay? So, yeah, we need something like a CERN-like project for an AI for longer, healthier, and safer life. The best place would be in Europe, because Europe is very good to create laws, but it's not good enough to really have big projects like we had before, like the CERN. We should use the millions of IT specialists and the millions of civil servants and the millions of people in medical fields who are paid by the states in Europe to work in common for this goal. Clinical trials, I have not a lot of time except to say that the HILS, my organization, is organizing a call for volunteers for longevity clinical trials that are the possible treatments who could be tested at the beginning. And I come already to the conclusion. So what I hope for, let's say, ideal European health data space, it's a system that is trusted by citizens, managed by a public institution or by public institutions in general, one each country, where by default, so it means opt-out, so it means that people who don't want, they can go out, but you don't have to say that you want to go in. All health data, anonymized or pseudonymized, can be used for scientific research and not for any other use, so that people are not afraid to share. This is, of course, to start clinical tests, clinical trials, and the final goal is to enable everyone wishing it, not going to be compulsory, to live a radically longer and healthier life. If you don't have enough time for the questions now, you can send me an email, even if you agree with me, but especially if you disagree. And there is a newsletter in English, French, Dutch, German, Spanish, and soon there will be also in Slovenian language about the news for healthy longevity, monthly newsletter. Thank you.
Thank you very much, Didier. So now questions. Anyone has a question? Yes, Mitya.
Thanks for the talk. I definitely very much agree with your desire for more accessible data, because I often struggle with exactly this problem. But I wanted to ask you about this clinical trials for longevity that you mentioned. Can you tell a bit more about that?
So at the moment, a few words more. I had no time to go. So this group of volunteers, it's at the moment a very small group, we ask two things. First, of course, that there is a good, that the teams who are proposing clinical trials has experience. Second, that at the same time we have tests on mice or rats and humans. And third, that there is a commitment to transparency and open results. And one of the problems of the clinical trials who are going on at the moment is that very often the organizations who are making clinical trials, they are afraid to have old people. So they are. So that's one of the problems, and that's why we are trying to have, I would say, older volunteers for this. And concerning what we could start for treatments, so metformin is. So there is since now, I think 10 years, what's called the TAME study, metformin study, that was supposed to start, once again, 10 years ago, and it's still not started. So that's one thing that could be tested. Rapamycin, it's probably the most well-known other compound. For me, the most, where my main hopes are, is concerning gene therapies. Gene therapies, especially targeting muscles and telomeres, but there are also other. Then there are all things related to plasma and other blood-related interventions. There are the caloric restrictions, mimetics, but that I'm less optimistic because probably it's working only for small animals. And you have another question, I see, no? Or
No, well, I don't know. Maybe a question, maybe not. I feel that the people interested in longevity should indeed be able to participate in some kind of trials, but probably a different kind of trials than are usually done, because this TAME trial never got started because it costs, I don't know, 50 million or something like that.
Yeah.
But I mean, taking metformin is not expensive.
No.
So the costs must be somewhere else, and perhaps they are not necessary. Perhaps this can be done in some different way. And I'm wondering if you're thinking about such different ways here.
Yeah, so I would say I tried this, and more precisely, Josh Mitteldorf and tried this with something called the data beta test. The idea was to have people not officially taking part to a clinical trial, but sharing their data together in some other organized way. But this is complicated because of what I said about ethical committees and so on. We when we tried that, we were blocked. Especially by what's called in the US and Canada, it's called the IRB, so it's the ethical committee, and we never succeeded. I had also something more to say about metformin. For me, it's kind of fascinating and depressing, because metformin is a product that people take since at least 20, 30 years, and we still don't know if it is working or not for longevity in general. And probably all the, when I was saying, so we have data for this, and probably we should know already, but when you speak to people informed about metformin, some people will say, oh, it's not anymore necessary to test because we know it's working, and other people will say exactly the contrary. It's not anymore necessary to test because we know it's not working. So it's and one thing more that I want to say, 60 million for the drug companies, it's nothing, you know, to the total price of a new drug from first research to market, it's $1 or $2 billion. So, and okay, you could say, no, you can say that the drug companies are not interested, but the public health institutions, they would have, it should be a no-brainer to start this, because there are millions of people taking this, because there are, tens of millions of people taking this, probably millions of people taking this for longevity. So if we have good results, we know that it is good, and we have bad results, we know that we have to stop people to take metformin for longevity. Well.
Sorry.
The accessibility
very fast, because then we have Zoom
very fast, yeah.
in 1 minute.
If the accessibility is not a problem, which supplements or chemical compounds would you recommend for longevity?
At the moment, to be short, to live longer and healthy, the first thing is a good choice of your parents. Okay, but that's too late. And the second thing is like what your great mother told you, so not too much, not too little. And I think that there is nothing that you can take, at least when you are young. Well, I'm sure that there is nothing that you can take when you are young that is for sure giving important results. So I would say, if there was something, at least 10 people here around would know about it. And I could go to make something else. Yeah.
What about metformin, taking it at the young age, for example? Because like
probably not.
The studies, apparently 80% of Americans have insulin resistance, and it's not. It's quite similar in Europe. So would that be beneficial for longevity if they will take metformin, for example?
I propose to continue the discussion.
Yeah, let's do it after.
But maybe just 10 seconds for Melissa.
Okay, Melissa, 10 seconds.
10.
Okay, thank you. Okay, a couple thoughts on metformin. First of all, it's taken by people with prediabetes. So to say that we have data about aging from that is sort of silly, because these are people that are already not on a great path, I suppose. So I would probably be on that side of it. I think we need to do the TAME trial. And I also don't think it would be that expensive, because you're right, at least $2 billion these days to get something through, all the way through the pathway. Data. we want it now. We want our own data more than we used to. We have Oura rings and watches and we have Whoops and everything else. Yeah. But do we want other people to have it? That's what I think is going to be the difficult part. And I know, I mean, you have a legal mind, but also a very philosophical one. I know it will be difficult, but what are your thoughts? Since you've thought so much about the data, how are we going to get people to want not only to have the data in the first place, to use it ourselves, but to share it with others, since we've been so steeped in not doing so?
So, two short things. Maybe an explanation for those who don't know about metformin. In short, there was a study that said that people having diabetes and taking metformin were living longer than people not having diabetes and not taking metformin. So if this is true, it means that really metformin is good. But there are discussions about this. I will not go into details. So second point, well, I said it, I think 2 or 3 times. I'm convinced that people don't want to share for only one reason. I would say only one rational reason is they don't want their data to be used for commercial goals, especially for commercial goals who could be detrimental to them. So if we say the data is for scientists and for no other reason, so I'm coming there, okay, too late.
I remember it.
If you say it's for sharing health data for scientists and nothing else, then normally it's okay.
And just a quick rejoinder, that might be true in Europe. It's not true in the US because people are very afraid that their data will be used against them to make their insurance more expensive or so
but that's what I say.
Can't have it.
Of course, but if there is in the law something making it impossible, the risk is, I would not say that the risk is 0, but the risk is not a lot. You know, you cannot... I'm pretty sure you are a woman, even though maybe you will be more complicated.
You never know.
Okay? And I'm pretty sure I'm a man, and I'm pretty sure you have a longer life expectancy than. But if the law say you cannot discriminate, even if not everybody knows that, they are not going to discriminate.
We could have a great conversation about it. Thank you.
Okay, applause for Didier.